I'm provided with the X-ray chest frontal projection and the lateral projection of a skeletally mature subject. There is evidence of multiple soft tissue density opacities in right lung field. Um, okay, these one of them is in the hilar region. The another I can appreciate is near the right CP angle. Correlating these on the lateral chest radiographs. Um, these are most likely, I cannot comment on their margins. There is no cavitation or calcification in these nodules. The hyla appear unremarkable and the CP angles are clear. The visualized bones are also unremarkable. Um, on the
So Roxana,
lateral,
your differentials?
okay. Sir, my differentials are that of the multiple pulmonary nodules. On the lateral chest radiograph, um, I can see there is a opacification is noted within the region of aorta and sorry, um,
So
my
this is the
differentials have
aortic
multiple
arch.
pulmonary nodules. I would like
Okay.
to take the history. Uh, if there is a history of primary, these are metastatic lesions. If there is an infection, history of any septic focus, this can be septic emboli, and they can be, however, there is no cavitation, but
Mhm.
the BDs of the cavitatory nodules will also be, I will put, next I would like to do CT scan with contrast of this patient to further evaluate.
Got it. Just a small point. What do you think the shape and the size of the lesion is? Oh, sorry, the characteristics. Are the margins round? They are spiculated? What do you think about them?
So for me, one of the lesion that appears to be in the anterior cardiopulmonary angle has a spiculated and slight irregular margins. So it
Mhm.
can
So
be
does
a
it change your
lamina.
differential?
Yes, now I will, if the margins are irregular, I will definitely put the differential of any neoplastic lesion.
Hmm. Okay.
Mm,
Um, you took the case very good. Honestly, the differentials would remain the same. Um, it's very difficult to see the cavitation inside these lesions, but on the lateral radiograph, do you think that there is some opacity over here inside the lesion?
yes, sir. There is some passivity, but I cannot appreciate any cavitation
Yeah,
in it.
no, fair enough. That's a good, very good description. Just start your description for CT scan as the images are going to come up.
Okay. Okay, I'm provided with the CT scan post-contrast axial images of the chest. There are multiple soft tissue density nodules are seen, at least two on the right side and one on the left side. One of them near the perihilar region is showing a cavitation inside it. Um, the one of them is near to the pleural surface on the right side. Okay. Um, there is a surrounding pneumonitis and is also noted around this perihilar lesion. Uh,
This one.
so these are now my differentials have been narrowed down. For me, it is like metastatic nodule.
Hmm. Got it.
Mats are my the final diagnosis.
Metastatic
However, being
lesions.
visualized, sorry,
Metastatic. You're going for the metastasis, right?
yes,
Got it.
I would further
Any
like
relation
this.
to the, this patient has no history of primary cancer.
Okay, uh,
Does it change your differential?
they can also be fungal.
Hmm. So
Uh,
what makes you think about the fungal lesions?
uh, the surrounding halo
Yeah. Okay.
density surrounded by a halo representing the invasive fungal infection.
Got it. But
Halo sign.
those are usually in the upper lobes, right? Over here.
Yes.
So there's just one lesion over here which does not have a significant ground glass, perilesional ground glass density,
Yes.
most commonly known as the halo sign. The fungal infection mostly would be in the upper lobes. This is more likely in the mid, like for example, in the interior segment of the right upper lobe, the superior segment of the left lower lobe, okay, and then in the medial segment of the right middle lobe, and the anterolateral basal segment of the right lower lobe. So they're mostly in the mid to lower lobe predominance, right?
Yes.
So does it change your differential? It's a very good differential. Fungal infection mostly would be in the differentials, but it's mostly in the mid to lower lobe. And the patient is otherwise well. He has a history of hemoptysis,
Okay.
and
Um,
there's no fever. The CRP is slightly raised. What do you want to think about serological findings? Do you want to do any test?
Sir, I want to do ANCA antibodies for the
Yeah,
vaginers.
got it. Good. So if you see a cavitating lesion with a perilesional ground glass density, more commonly called as halo sign, think about vasculitis. And another thing that you see that it's in very close proximity to the vessels. See,
Okay.
all of
Yes.
these lesions, they are coming, they are in very close proximity to the lesion, to the vessels. So think about vasculitis as well. Okay.
Okay.
So this is a case of granulomatous polyangiitis, previously known as Wagner's granulomatosis. Um, Radiographs can be normal, could be multiple lung nodules with masses plus minus cavitation. Honestly, this radiograph was reported having a slight a slight low opacity in the lateral radiograph that I showed you. So we said that it could be a cavitating lesion, but the differentials remain the same, just like the way you said.
Okay, so I'm provided with a frontal and lateral radiograph of an adult female patient. So I'm starting from the center. So there is the trachea is slightly shifted towards the left side, and there is a asymmetric radiopacity in the right paratracheal region. The bifurcation is okay. The heart size appears to be slightly enlarged and slightly more towards the left side. However, also the left lung volumes appears to be slightly reduced as compared to the right side. The breast shadows are okay. The diaphragmatic cell hits are intact. There
Mhm.
is a radiopacity, also an asymmetric radiopacity in the right hilar region. The costophrenic angles are clear. Below the diaphragm, it's normal. Okay, and the ribs are normal. There is no lytic or sclerotic lesion in the ribs and all the involute bones. Um,
Mhm. So
on
do
the
you want to
lateral
describe the
radiograph,
opacity? Do you want to describe the opacity that you saw in the right paratracheal region?
yes, sir. On the lateral just radiograph, I'm able to appreciate that the right hilar region is slightly rounded in nature with few lobulations, and
Mhm.
there is the retrotracheal region is okay. So only this is a solitary right hilar radiopacity. The vertebral bodies are
Are you talking about
normal.
this opacity?
Yes, sir. So which is also appreciable on the lateral X-ray.
But this opacity, Dr. Pushpak, has some sort
Ji,
of
sir.
dividing pattern, see?
Yes, sir.
And it's a very common location for right infrahilar pulmonary artery, right inferior
So no,
pulmonary
sir. I'm
artery.
explaining the lateral X-ray, the lateral chest radiograph.
So you're talking about this one, right?
Yes, sir.
So this is not this thing.
Okay, sir. Okay, sir.
So this area is most likely over here in the infrahilar region. See,
Fine,
this
sir.
is the hilar,
Yes, sir.
and this is the hilar. So we're talking about infrahilar lesion. So infrahilar would be approximately over here.
Okay, sir.
Okay. So
Yes.
I told you that you said something about
Yes,
right
sir. Right
paratracheal
paratracheal
opacity.
opacity. Yes, sir. Yes, sir.
Yeah.
Sir, this
So
opacity is causing slight mass effect over the trachea, and it is slightly shifted towards the left side. So
mhm.
this opacity is reaching up to the lung, right lung apices, because the left lung apex appears to be clear. So
Mhm.
it can be either posterior mediastinal lesion or an anterior mediastinal lesion, which is reaching above the clavicles and causing mass effect on the trachea. On the lateral
So what do you think?
radiograph,
It's a anterior mediastinal or posterior mediastinal?
uh, so on the lateral, I'm trying to zoom the image so that I'm able to appreciate this.
I think so. The clue lies on the frontal radiograph.
So it must be likely posterior mediastinal because the lesion is going above the clavicles.
So if the lesion was going above the clavicle, it should be coming up here, right? So I can see a lucency over here.
Sir,
That's
okay,
quite
sir.
comparable from here,
Okay, sir.
right?
Sir, so this is a, sir, if this is a young female and so I am, it may be anterior mediastinal because of the location. I'm thinking
Okay,
of the anterior mediastinal lesion with such mass effect on the trachea.
okay.
So next, I would like to confirm my finding. I can perform an ultrasound neck,
Mhm.
and or I will proceed with a CT, neck and chest
So
with
another thing,
contrast.
this is called a satisfaction of search error. So you saw one opacity and you said that there could be nothing else, right?
Yes, sir.
Just go through the trachea. So you're looking at the lucency of trachea over here. That's the right main bronchus. What's happening to the left main bronchus?
Sir, it is tapering towards the its end, like it's
Yeah,
normal proximal caliber.
yeah. And
Yes, sir.
what's happening distally as
So,
well?
so distally is so there is so the diaphragmatic contour is intact. So, however, there
Mhm.
is a radio opacity in the retrocardiac region, but the
Yes.
as the lung volume is reduced on the left side, so it can be an
Yeah.
endobronchial lesion in the left bronchus, inside the left bronchus.
Mm.
So I would like to
So
confirm it on the CT chest with contrast.
now, given that you have this right paratracheal opacity and obscuration of the left main bronchus, then a retrocardiac opacity, what are your differentials? And what are you getting
Uh,
at?
Sir, in the young age, sir, it can be a central tumor which is causing the collapse of the lung.
Mhm.
So the endobronchial lesions include, sir, carcinoid tumors,
Okay,
and it can be, sir, if it would have been a metastatic lesion, I would expect more lesion in the lung parenchyma as well. So I'm thinking of a
mm,
central endobronchial carcinoid tumor, which is causing
got
the
it.
collapse of the lung segment.
Very good.
Yes,
So, what do you think about what do you know about carcinoid? Like, there's an endobronchial lesion over here, right? So, what is
yes, sir.
this?
So it can be causing involvement of the, sir, I've heard of SVC syndrome, and
Mhm.
if it metastasizes into the body as well, so it can cause clinical presentation and variable form like flushing, diarrhea, and hypertension. And
Okay.
if so,
So,
it
you're
can be
trying
a
to tell
secondary
me
manifestation.
carcinoid disease and carcinoid syndrome, right?
Yes, sir.
So, this patient does not have flushing, but
Okay, sir.
she said when I took the history, she said that she had some sort of flushing disease and problems in the past. And
Uh, okay, sir.
does it help you?
Sir, can I, sir, can I take help from another investigation, like in a staging investigation to look for its
Mhm.
further extent or spread in the body.
Yeah. So you, number one thing that I just want to make clear, always ask for previous history, previous comparison radiographs. Okay,
Okay,
just make
sir.
a habit out of it. Always ask for a comparison radiograph. Okay,
Yes, sir.
now when we're giving FCPS Viva, um,
Yes, sir.
this thing, even if the examiner doesn't show you the radiographs or comparison studies, this thing by
Yes, sir.
saying has its points. Okay, so whenever you say that I want to look at the previous radiographs, the examiner
Fine, sir.
knows that what you're looking at. Okay, and
Okay, sir.
he has set amount of points for for this line, even though it's
Yes, sir.
quite possible that he doesn't have previous imaging. For example, in this patient, I do not have any previous imaging. So what do you think now?
Um, Sir, these are multiple contrast enhanced CT images of an adult female patient. Sir, there is a soft tissue density area surrounding the descending thoracic aorta
Yeah.
with few enhancing areas. The there is the esophagus appears to be normal. The rest of the heart chambers are also normal. The cardiac shadow appears to be normal. So
Mhm.
this lesion is causing encasement of the descending thoracic aorta,
Okay.
and mm, whereas there is no hilar,
Mhm.
the right hilar, there is no hilar adenopathy. So
So number
the
one,
breast shadows are
this
okay. The
lesion
bones are
is
okay.
you, Dr. Kushberg, when you say that it's this lesion is surrounding descending thoracic aorta, are you changing the location of the lesion? What do you think? When we say that the lesion is surrounding, like in a report, when we would say that if the lesion is surrounding the descending thoracic aorta, doesn't it imply that it's in the posterior mediastinum?
Yes, sir.
Mm-hmm.
So, so if I would like to see the rest of the images, if there can be multiple lesions, sir.
Okay. So unfortunately, I do not have the rest of the images, but these are the diagnostic images. Your findings
Okay,
are absolutely right. And honestly, you have clinched the right diagnosis. I just want you to explain what you are seeing.
okay, sir. So, sir, it is. So I'm not able to think any further,
Mhm.
sir.
So
That's why I'm
how
just
I
trying to.
would how I would report is that there is an enhancing mass in the most expected position of left lower lobe, posterior medial basal segment, okay,
Okay, sir.
which has
Yes.
resulted into the collapse. And I can see a relatively hypodense mass over here, which seems to be extend into the left lower lobe bronchus. That was the thing that we were seeing on the radiograph, right?
Yes, sir. Yes, sir.
And it seems to be extending into it, and which is further causing
The
distal
collapse.
atelectasis. Okay. Now we know that when the lung is collapsed, what is the enhancement pattern of a collapsed lung?
Sir, it doesn't enhance relative to the normal lung parenchyma.
Okay. The atelectatic lung always enhances. Okay.
Okay, sir.
When you see atelectasis, it is always enhancing. That the key reason to differentiate between an atelectatic lung and a
Yes, sir.
consolidation. Okay,
Okay, sir. Yes, sir.
so atelectasis would always enhance, and if there is any pneumonia, for example, in aspiration pneumonia, where there could be just some sort of right posterior medial basal atelectasis, which is enhancing, surrounding a non-enhancing area, which is basically the area of infection. Okay,
Yes, sir.
so this all atelectatic lung is basically enhancing, right? So the lesion is
Yes.
actually inside this enhancing lung. Okay, and see the hypoenhancing part is in it's encroaching into the left main bronchus. And if you see, there is some differential hyperdensity in the lesion. Like this is not a vascular vessels, right? This is
Yes, sir.
different than the vessels. This is calcification.
Okay.
Although It's difficult to say on these images. I agree. That's why I'm telling you. But calcifications, you should look at them. Okay. And
Yes, sir.
what do you think is the diagnostic test for um, for this limb? If you're thinking that this is a carcinoid, what is the diagnostic test that you want to do?
So for carcinoid, we do octreotide scan.
Okay. So there you go. So what do you think on octreotide scan?
Surgery is So there is increased uptake. The radio. So I'm not able to
No problem. No
actually
problem.
interpret this.
No problem. So these are multiple
Yes, sir.
spot images from octreotide scan, and the crossover hairs over here are basically shown over here. So this is giving high uptake over here. Okay. So this is increased uptake of octreotide over here. So this confirms that this is a carcinoid.
Yes, sir.
Okay.
Yes, sir.
So the first thing that you said on this radiograph, I just wanted to explain is, what do you think about the cervicothoracic sign? That's a very important thing.
So cervical thoracic spine.
Yeah.
So it's so on the lateral and lateral. So the spine is looking normal. So spine is
No, no,
okay.
I'm talking about cervicothoracic sign.
Cervicothoracic sign. Sorry, sir. Yes, sir,
Yeah.
sir. To me, I was thinking of this radiopacity, which is crossing the, reaching up to the lung apice. But when I looked it back, and then I
So
was
how do you
able to
explain it?
appreciate it.
Like if the cervicothoracic sign is positive, what do you mean?
So we characterize those lesions, whether if they are from arising from the posterior mediastinum, like
Okay.
those lesions which would be crossing the clavicle, they will be like from posterior
Yeah.
mediastinum and they will be reaching
Yeah.
the lung. So
Good.
yes,
So this is a very important question. I got this question on my FCPS part two, so that's why I'm asking you.
yes, sir.
Okay. So this is a case of pulmonary carcinoid, which was picked up by you. It's a single hilar or it's a perihilar mass. So these are basically two lesions of carcinoid. One was in the right peritracheal lesion, and the other was in the invading into the right lower lobe bronchus. So you know that there are peripheral lesions. There are central and a peripheral lesion. So these were all the one in the left lower lobe was a central lesion, and the one in the right upper lobe was the peripheral lesion. Okay, and this has
Thank you,
sometimes
sir.
this have eccentric calcifications. Very good. So a young
So
female.
I'm present. So chest X-ray, frontal projection of a skeletally mature, frontal and the lateral projections of a skeletally mature female patient. So in this X-ray, I would like, I appreciate there is a bilateral hilar lymphadenopathy. Bilateral hilar lymph nodes are enlarged, and moreover, I can see the cardiac shadow also appears to be enlarged. But I would like to see to take the CTR and my normal clinical practice. In the rest of the lung fields, I can see there is somewhat like the upper lobe diversion or the sporadic lesions are noted in bilateral upper lobes. And however, the lung volumes are preserved. I don't appreciate any evidence of any nodular opacities in the bilateral lungs. Pulmonary chorus is also prominent. Um, Moreover, I can see there is an evidence of a retrocardiac opacity is noted, which is predominantly in the left paraspinal location. Now, in the lateral X-ray, I can see um, that um, I don't appreciate this opacity. I think this was not there. So, all the visualized bones appear unremarkable, and no other bilateral CP angles also appear normal. So,
So just to
considering the
summarize, can you
yes,
summarize your
so in this
findings?
case, my top differential would be sarcoidosis.
Okay.
And although I don't see the actual calcifications, but considering the bilateral symmetrical hydrolymphadenopathy,
Other differentials would be lymphoma, although lymphoma is not that symmetrical, and the TB could be a differential, but this is also less likely because
So,
only primary can cause.
why are you basing your diagnosis as sarcoidosis? So, what are the supportive findings?
So because of the bilateral symmetrical hyaline lymphadenopathy, female patient and middle-aged, that's why.
Isn't
And I would
sarcoid
like
more common in males?
no, so sarcoid is slightly more common in females, as far as I know.
Okay, so we will look at it together.
But I
So,
don't find any right paratracheal lymphadenopathy, moreover.
yeah,
And
okay.
next, I would like to take the history of the patient for any joint pains or any other systemic findings, and would like to do the CT scan, CT chest,
So
HRCT
you
of the
said
patient.
before we going towards the CT scan, the first thing that was important that we should always ask for imaging. And at the very top, I said chest radiograph to 2017. So
Yes.
this should make you think that I should have more radiographs, right?
Okay, so I want to see the
And
latest or the recent
and
radiograph.
how do you fix a retrocardiac opacity into
So
the
I don't find
diagnosis
it
of
in the lateral
sarcoid?
radiographs. That's why I thought that maybe it was a projectional or because I
Mhm.
don't find it on the lateral radiograph.
But there's definitely on frontal radiograph, isn't it?
Yes, sir. I feel that it is there. Maybe it is in the anterior mediastinum, and it is merged in the cardiac shadow on the lateral radiograph. That's why I'm unable to appreciate it. But I
So
thought that maybe it
this
is
is the
in.
retrocardiac opacity
Yes, sir. I thought
coming
this
over
is.
here. Then it is saluting the medium portion of the diaphragm. Then it's also coming over here, isn't it?
Yes, sir. But
So
sir,
it's
I'm
also in the
unable
right
to appreciate
paraspinal
it
space.
on the. Maybe it is in the anterior mediastinum.
No,
Then
there's a reason that you cannot see it on the. Well, you can see it on the lateral radiograph. So
okay.
how would you explain this retrocardiac opacity into sarcoid?
Hmm.
And this patient is a young female.
Okay. Since sarcoidosis, although we don't find any pectoralis, esophagus is not in spectrum of the sarcoidosis, and
Pectoralis esophagus is in scleroderma.
yes,
So
sir, that's not in the
just for the
sarcoidosis.
sake that some people are saying we should be a bit more fast. This I don't think so. This is lymphadenopathy, is it?
Dr. Kaval,
So
please mute your mic, Dr. Kaval. Dr. Kaval, please everyone check your mics.
sorry.
Keep them
So
muted.
as I was saying that this patient is a young female, and what do you think about the heart shadow?
So then it could be bilateral enlarged pulmonary arteries because the right inferior pulmonary artery is also very prominent. So it could be the bilateral enlarged pulmonary arteries with peripheral pruning of the vessels, and it could be a case of the pulmonary artery hypertension.
Okay, that's good. So now, what do you think about the retrocardiac opacity?
This in now the retrocardiac capacity.
Okay, so what do you think about the direction of the carina? Is it normal
Then it's the right
bifurcation of
heart.
the carina?
Okay. So it's a left heart double border sign on the left heart border. Maybe you're talking
Sorry,
about that.
can you please say that again?
You're talking about the left heart border, double heart border
No, I'm
on the
talking. Yes. Basically,
double
that's a
heart
double
border and the
density
widening
sign.
of the carina and the
Yeah,
slitting of the left heart
yeah.
border. All the
So now you get it. Where is the retrocardiac opacity on the lateral radiograph?
yes, sir. So it is in the posterior
Yes. And
because
what
it's
is it?
so it's dilated left atrium.
Yes. So what are the causes?
Mitral stenosis
Okay.
and the mitral valve diseases mostly.
So that's the radiograph in 2019.
Okay.
Now what do you
So in
think?
this radiograph, okay, in this X-ray, I can appreciate that the stenotomy sutures are seen. Moreover, cardiac pacemaker is seen with its lead is seen in the right atrium. it is normally placed.
So
And I think
just to correct you over here, don't say pacemaker. I used to do the same mistake. Don't say pacemaker, just say intracardiac device, okay?
okay.
Because you do not know that whether it's a pacemaker, whether it's a cardiac resynchronization device, whether it's an
Mm-hmm.
ICD, just say intracardiac device, or just
Okay.
say some electric device, probably an ICD, because it's a single lead. The patient is young. I don't think so that they would do a pacemaker. They would just put an ICD.
Okay. Moreover, I can see there is a mitral valve replacement is seen in situ in the lateral radiograph.
Got it.
So I think the patient has been operated for now for the mitral valve disease, and now I can see there is a resolution of. I can still appreciate the left heart border enlargement, but it is slightly resolved as compared to the previous one. And pulmonary
Okay.
arterial hypertension is also there, and
Okay. So what do you think about the prosthesis?
so it's mitral valve prosthesis as
Mhm.
its direction is downwards from
Yes.
the atria into the ventricle.
What is this one?
So this is cardiac device lead.
No, the lead is over here. What is this ring shape opacity over here?
So which one?
Uh, can you see my pointer?
Yes, sir.
So I'm pointing it out for you.
Okay. Okay. So this is arising from the neck and extending inferiorly.
Mhm.
It is something
So what is the
else.
location?
It is pointing towards the, if it is in the heart, no, it is towards the IVC. I think it is.
Yeah. Okay. That's very good. It's towards the IVC. It's a tricuspid annuloplasty ring. Okay.
Okay.
So on the frontal radiograph, see there's a dilatation of the left atrium, but over here there's also dilatation of the right atrium. Okay. So
Mhm.
they
So
went
it's
in.
progressing towards the IVC.
Yes, this patient had severe mitral and tricuspid regurgitation as well. So what they did was they did a tricuspid annuloplasty to reduce the diameter or the circumference of the tricuspid annulus so that they could get rid of tricuspid regurgitation. Okay, and
Mhm.
just one thing, what do you think about these lines? You missed them.
These are curly V lines because of the pleural
Yes.
effusion also blunted right. Actually, in this case, the patient now has developed the pulmonary venous hypertension along with arterial hypertension.
Good. So basically, the person is also in some sort of congestive heart failure, right? There's effusions as
Okay.
well.
Okay.
So now I want you to see this thing. Where is
Yes,
it?
sir.
I'm sorry. This pointer is a bit of a problem.
Okay.
So
CT
start
scan
explaining.
chest. Yes,
Yes.
sir. CT scan chest axial sections. Soft tissue window is provided in the post contrast enhanced images. In these images, I can appreciate there is uh, sorry, sir, a bit slow. Okay,
Okay.
there is in the descending aorta. Mm, so I want to see the
So
ascending aorta, arch of the aorta once again.
this is the ascending.
Yeah. So I can see a thin flap is seen in the arch of the aorta as well as extending into the descending aorta, in keeping with the dissection. And however,
Mhm.
I can see there is almost there is a non-opacification of the left side of the descending aorta. So it could be the intramural hematoma or the thrombosed dissection in the
Good.
descending thoracic aorta.
Yes. So this patient had a type A
And
dissection. Can you tell
type
me
A
the types of the
dissection.
dissection quickly?
Yes, sir. So, Stanford type A, in which the ascending is always involved, and Stanford type B, in which instead of only descending is involved. But
Got it.
whenever there is
So what do
ascending,
you think
always
about the
descending.
PA? What do you think about
And so
the main
pulmonary
pulmonary
artery is
artery?
also enlarged more than the artery, and we will call it the pulmonary hypertension. It's more than the 3 centimeter, and it's relative to the aorta, it's more enlarged. So it's a
So
feature of
another
pulmonary
thing,
artery hypertension.
satisfaction of search error. There's another thing in the MPA.
Okay.
See it again.
In
What is that? Quickly.
so which one?
There's another thing in the main pulmonary artery.
So
What is
in the
this?
okay, there is also a flap in the main pulmonary artery. Uh,
So what is this?
which is incomplete and mainly in the arch of the mainly the main pulmonary artery, not extending into the branches.
Okay.
So it could be an intimal tear again, but it's very unlikely to. I have not seen it
Yes.
in the pulmonary arteries.
Yes. This is my first case of main pulmonary artery dissection. Okay.
Okay.
This is very rare and no one knows what to do about it. Okay.
Mm-hmm.
So
Okay.
the professor of cardiothoracic surgery with whom I report, he said that this is his second case in his career, and that is almost like 40 years.
Mm-hmm.
So this is main pulmonary artery dissection as well. Okay.
Okay.
And
Okay.
no one knows what to do about it. So to sum it
Mm-hmm.
up, what do you think it is?
So then
Just one
it
line
could be
answer.
some collagen disease probably will be there. The
Yeah.
multiple intimal tears could
Yeah.
be the like the Marfan's Ehlers-Danlos or any other diseases congenital.
Well, yeah,
Although I
you
don't
just
see.
make it broad, keep it broad. It could be connected tissue disease, fair enough.
Okay.
It could be connected tissue disease. But what do you think about what's happening right now? You said it's a pulmonary hypertension, right?
Mm-hmm.
So can you go over which class of pulmonary hypertension it is? Because it's not an idiopathic pulmonary hypertension, five types. Class 2 was due to left heart disease, and class 3 was due to the lung diseases, which we always
Okay.
see. Okay, thank you very much.
Okay.
Very good.
Sir, I am provided with plain radiograph chest, frontal and lateral view of a skeletally mature patient. Here I can appreciate I can appreciate abnormal areas of pacification involving bilateral parahilar regions, which is extending up to the which is extending from the perihilar regions to the periphery of the lung, and mm, no other lesion is noted. Bilateral CP angles are also normal.
Mhm. So differentials.
So it could be enlarged. So these are not lymph nodes. These are not enlarged lymph nodes. So bilateral. These are bilateral perihilar opacifications, areas of opacifications.
Yeah.
Sir, heart size appearing normal. So rest of the lungs, they are also normal. So
Yep.
based on
The
these,
rest of everything is normal. What do you think about these opacities? The location of the opacities. Tell me about the shape of the opacities, the surrounding lungs. What do you think about all of them?
so these are rounded opacities with irregular severe margins. They are, sir, extending into the lung.
Yeah. Okay.
So there could be so areas of opacifications, consolidations. They could be
Okay.
perihilar consolidations.
Mm-hmm. Okay. Go
So
on.
based on these findings, my differentials, these could be central perihilar pacifications. So differentials includes so it could be a case of non-cardiogenic pulmonary edema. So it could be
Okay.
perihilar consolidation. So it could be, so if patient is immunocompromised, then sir it could be Kaposi sarcoma.
Kaposi is not like this.
Yes, sir. So it could be
So
sir.
these are basically radiating opacities in the
Yes,
perihilar
sir.
region. Okay.
Yes, sir. Yes, sir.
Sort of ill-defined opacities, large opacities. This is basically the aortic notch. If you
Yes,
look on the
sir.
lateral radiograph, this is your airway. And what do you think over here? What is
So they are,
this? These opacities over here.
they are causing mild compression over the main bronchi.
Yes, could be. It's not a compression. It's basically it's a haphazard thing, right? It's
Yes, sir.
it's an architectural distortion, I would say.
Yes, sir. Okay.
And what do you think about this opacity below the airways? What is this? So whenever you have opacities over here on the lateral radiograph, that's the infrahilar region. Always think about lymph nodes, right?
Yes, sir. Okay, sir.
And
Okay.
what do you think about the
Sir, on the
surrounding parenchyma over here? It's
sir,
kind
sir,
of like it's all stretched
sir,
out.
mild. Yes, sir.
So differentials.
Mm,
So
sir,
what if the
base.
opacities, if you're seeing them over here, were in the lung apices? What would be your differentials?
Sir, on the lung apices, sir, it could be
Yeah.
fibrotic in nature.
Yeah. Okay. So, but these are perihilar. I'm talking about if these opacities were in the lung apices, your
Yes,
differentials
sir.
would be progressive massive fibrosis, right?
Yes, sir.
PMF.
Yes,
But
of course.
if they are in the hilar region, what would you think?
Sir, in the perihilar regions, branching, radiating opacities. Sir,
Yeah. The most common thing in our society.
sir, post-infective,
Yeah. Could be post-infective. Post-infection from
yes, sir.
what?
It's tuberculosis.
It could
No,
be
sir.
post-tuberculosis,
Yes,
but
sir.
this is not a case of tuberculosis. You know that I'm
Yes, sir.
showing you cases from Canada, and they say that they do not have tuberculosis over here, but I have seen few. So let's see quickly see the CT
Yes,
scan.
sir. Yes, sir. Sir, these are X-ray images of CT chest with IV contrast. I am provided with soft tissue window. Here I can appreciate, um, sir, bilateral perihilar soft tissue densities with irregular margins. They are appreciated bilaterally. So these are showing, so these are causing encasement.
Mhm.
So on the right side, sir, it is causing encasement of the
So these are
these are
bilateral
branching.
perihilar consolidative
Yes,
and
sir.
fibrotic opacities, right? Fibrotic
Yes, sir.
consolidations, kind of reduced lung volume. Look at the lucency of the lung over here. Look at the lucency over it's quite
Sir, it could
reduced,
be a
right?
case of fibrosing mediastinitis.
Fibrosing mediastinitis, you would see fibrosis in the anterior mediastinum over here. Look at the fat over here. The
Yes, sir.
fat
Sir,
is
fat is
completely clear.
yes,
There's
sir.
no thickening of the mediastinal pleura. Like even the mediastinum over here is clear fat signal. Okay, so
Yes,
this
sir.
is not fibrosing mediastinitis.
Yeah.
What do you think about these lymph nodes?
Yes, sir. So multiple enlarged lymph nodes are appreciated. So
Yeah.
predominant involving pretracheal,
So
precardial, sir.
yeah, okay. So what do you think about the characteristics of the lymph nodes? What is in them? Don't you think see that there are hyperdense? What do you think about them?
Yes. Yes, sir. Internal hyperdensity, sir. They are also appreciated within these lymph nodes. So these are all lymph nodes, or there are some other.
Well, they are quite round, and
Yes, sir.
they do not seem to be continuous with the vessels.
Yes, sir.
So these are probably lymph nodes, and they have internal hyperdensity. They're increased density internally.
Yes, sir.
So what does this make you think? Is there anything?
So
So,
hyperdense.
so
Sir,
if I say that, if I
sir,
tell you that this is some sort of
sir, basic.
calcified lymph nodes with icing sugar type of calcification.
Um, sir, I think it is a syndrome, sir. I can't able to appreciate.
It's okay, no problem. That's why we are doing it. So if I say that this is stage 4 sarcoidosis,
Yes, sir.
what do you think about like? See, this is the calcification. These are the calcif. This is basically an icy sugar kind of calcification in the lymph
Yes, sir.
nodes,
Yes, sir.
and there are huge perihilar consolidative and fibrotic changes on the lung window. Just look at them. There's also cavity formation. Okay.
Yes, yes, sir.
Okay. And in the cavity formation, you know that whenever there's a cavity formation, the lung parenchyma is destroyed. So this patient had multiple superimposed bacterial and fungal infection, which led to these forms of air trapping, the lucencies in the lung. So
Yes,
this is a case of
emphasis.
stage 4. Yeah. So this is the case of stage 4 sarcoidosis. Okay?
Yes, sir. Thank you, sir.
The peripheral
So whenever you
parana.
see this radiograph looks daringly normal, right?
Yes, sir.
So
On
whenever you have
lateral,
a normal radiograph, what do you want to see?
so we have to see about the hidden areas, which will
Yeah.
be, yes, sir,
So
retrocardiac and the bones,
okay. So there's
epithelium.
nothing in the bones.
Uh,
And what do you think about the lateral radiograph? Does this seems to be abnormal to you?
sir, on the lateral radiograph, I can see the retrosternal space appears to be normal retrocardiac
Yeah.
space.
Yeah, these lucencies are completely normal.
Yes, the translucencies of the lower vertebrae are not uh, translucent as compared to the upper.
Yeah.
So,
So there's a good gradient of increasing lucency as we go down, which is normal. And there's another thing that is absent over here, or it's less pronounced. What do you think about the arch of aorta?
yes, the arch of aorta is small as
It's
compared to.
small. So does it tell you anything?
Um,
What should you look for on the frontal radiograph?
Here we will on the right side no any uh, aortic arch, right aortic arch. So no, there is no any evidence of right-sided aortic arch.
Mhm.
Then we will see any valvular disease, septal
Okay.
disease. So no oliguria is seen on bilateral. Uh,
So if you say that you do not see a well-defined aortic arch, right?
yes, sir.
So I would repeat my question. What do you think you should see on the frontal radiograph? What do you think are these lines?
Notching, inferior rib notching.
Okay.
Yes, yes,
So that's my question. Whenever you have a completely normal looking X-ray, always look for inferior rib notching, a small apical pneumothorax,
yes.
small rib fracture, a retrocardiac opacity, and an opacity behind the liver and the spleen. Okay.
Yes.
So what do you think now?
Coarctation of aorta,
Sorry?
post-ductal coarctation of aorta.
No, Dr. Please try to take up the image like what it is. Try to go from, make it a habit. Like, what is this? What is it showing? I know that there's coarctation of aorta, but there's one thing else. And what type of image this is?
3D, sir, reconstruction image of
Yeah,
uh, heart and the great vessel.
yeah.
Uh, so
So this
there
is a volume rendered 3D image, which is showing number one, coarctation. Number two,
stenotic. So there are multiple collaterals are seen
yeah.
around the large vessels, great vessels.
Hmm. That is the cause
Uh,
of notching.
yes,
And there's one other thing.
post-ductal coarctation is
Yeah. So what do you think about the ascending aorta? Look at the
the
size of the
segment
ascending
is
aorta.
dilated.
Yeah.
It is dilated, and
Okay.
so
So if
uh,
you have a dilated ascending thoracic aorta and a coarctation of aorta in a patient who is a female, what would you think?
um, just dilated any female patient
So
like that.
the I would repeat it. Dilated ascending thoracic aorta, coarctation of aorta, female patient. There's one thing that you need to see to clinch the diagnosis. So let me help you over here. So what if this patient has bicuspid aortic valve?
Yes, sir. Sorry, sir. Association. I mean, bicuspid
So what is
and
the association?
sir, the bicuspid valve.
Yeah.
It,
Bicuspid aortic valve, uh, aortic aneurysm, coarctation, female patient. This is Turner
syndrome,
syndrome. Turner
syndrome,
syndrome, X naught. So
syndrome.
Turner syndrome patients usually have postductal aortic coarctation, aortic aneurysm, and bicuspid aortic valve. Okay?
Mhm.
Presented with X-ray chest frontal projection and lateral projection of a skeletally mature patient, in which I am able to appreciate that there appears to be normal cardiac border with prominent aortic arch and with a calcification surrounding it, which doesn't appear to be displaced. The heart appears to be in normal limits. CP angles are clear, and trachea and mediastinum appears to be central. I'm able to appreciate that there appears to be bilateral reticular shadowing
Yeah.
seen, which are distributed evenly in both lung fields with no zonal preference. And the same finding is appreciated on the lateral X-ray. So I, considering it to be a female, I'm suspecting that patient might have some cystic lung disease, for which I would further go for CT images to confirm my findings.
So any
Like
differentials
it
you want
could,
to give?
yes, it could. I will ask, considering to be a female, my first provisional diagnosis is this could be a lamb. And since I am unable to appreciate any nodularity in this pattern, but so LCH would be my second differential. And I will also correlate with the history of smoking. That will also be very informative in this case. And third, it could be a case of lymphocytic interstitial pneumonia, where that might also present with multiple cystic changes.
Got it. But
Uh,
what is the zonal predominance for lymphocytic interstitial pneumonia?
um, so usually, I can remember it is associated with some autoimmune disorder like Sjogren or Zika syndrome. So you have to inquire about that.
LIP,
And
you're talking about lymphocytic? Okay,
yes, sir.
you
Yes, sir.
remember it. Okay. But what do you think about the zonal predominance of the LIP?
So I can't really recall it
It's low,
properly.
low. So
Yes.
very good description. Very good description. Female patient, extensive reticular markings. One thing that I want to point out, you reached the right diagnosis, but one thing that might have points would be lung volume. So
So
there is
I
a
think there is
differential.
some, sorry to interrupt. There's some
Please.
emphysematous changes in the upper lobes, and disease is more pronounced in the mid and lower zones.
Yeah, so you should point out that there is extensive reticular markings throughout the
Right,
lungs.
sir.
Okay, more common in the mid to low lobes, with
Right, sir.
normal or increased volumes. When I say
So I think
normal
there.
or increased volumes, I'm excluding fibrosis.
Right, sir.
Okay, so that's the differential point. And the other thing that I want to make a point is that please do not use abbreviations. Okay,
Sorry, sir.
our examiners do not like abbreviation. Number one.
Right.
And number two, when you said that you have displaced aortic calcification, like this patient does not have displaced aortic calcification,
I said, sir,
what is the point that you're trying to make?
no, sir. I was just pointing that it is non-displaced aortic calcification. I never said it was displaced.
No. I said that I'm telling you that you said non-displaced, but what is the point that you're trying to make?
So it's just to rule out some aortic pathology. It usually occurs in aortic aneurysm, but this aortic counter appears to be well defined, and the calcification is not displaced. So on the X-ray, it essentially rules out
Dissection?
aortic aneurysm. No aortic aneurysm or hematoma that might have intramural
It's
hematoma
yeah.
that might have
The point that
displacement.
I'm trying to make over here is that I think so, in my opinion, in my humble opinion, that radiograph is not sensitive or specific enough to exclude or include aortic dissection, aortic aneurysms. Like if you have a very huge anterior mediastinal opacity, that could be a lymphoma as well. Okay,
Yeah.
it's very non-specific. to say that if it's a I'm just making a point that
Right.
because whenever you say something, the examiner would catch it because you have reached the final diagnosis, and it is a case of lymphangioleiomyomatosis. So
Right.
just for the sake of everyone to see, what do you think about the?
Yes, sir. So I'm provided with lung window axial CT images. There appears to be fairly defined cystic lesions in the lung, which appears to be of normal size and perceptible walls with no nodularity. And I would also like to look at the further images to see to see the evidence of any effusion, chylous effusion, which is also associated in it, or any sign of
Good.
pneumothorax. And I
Good.
will also look for its associations like any lymphangioma in the interior mediastinum, or I will also correlate with the history of tuberous sclerosis in this
Good,
patient.
good, very good. And just one point that I wanted to make is that the intervening lung parenchyma is normal.
Yes, sir.
Okay, it has
Normal.
it has num points. So if you want to get full points from this exam on this station, just tell that there are multiple cysts of variable sizes with normal intervening lung parenchyma. Okay, so this is lymphangioleiomyomatosis, and consider LAM in women with diffuse bilateral thin wall cyst plus minus pneumothorax or pleural effusion. And I should have asked you earlier, do you remember any syndrome with lymphangioleiomyomatosis?
So tuberous sclerosis is
Relatively mature patient. Yeah, I can appreciate trachea is central. There is no mediastinal shift. Cardiothoracic ratio is within normal limits. There is a broad-based, well-defined radio opacity that is projecting over the left side of superior mediastinum, and it is forming a broad angle with the mediastinum and obtuse angle with the lung parenchyma. So it is mediastinal in origin and extrapulmonary. Um, there is no internal cavitation or calcification in this opacity. I'm looking at the bilateral lung fields. I cannot appreciate any gross evidence of airspace opacification, consolidation, cavitation, or calcification. Bilateral CT are unremarkable. Bilateral apices are comparable. Hilar regions normal. No retrocardic opacity. And next I'm looking at the soft tissues and bones. Um,
Those are all normal. Just
okay, these
focus on
are
the opacity
normal.
that you saw. You're absolutely right. Whenever there is smoking, history of smoking, all of these central lobular nodules, which are mid to upper lobe predominant, there's a spectrum of respiratory bronchiolitis. Like respiratory bronchiolitis, ILD is not a disease entity in itself. Try to consider it. There's a area of lucency over here, right?
Yes, yes, yes,
And there are some lobulated lucencies over here as well. And then
yes,
surrounding this area, there's a generalized areas of differential lucency. Okay.
yes,
So if you look
mm,
at the sagittal reformat, there's sort of
yes.
a cyst-like and cystic areas with surrounding areas of air trapping.
Okay.
So this
Mm,
patient had multiple pneumothorax in the past as well.
pneumo- uh,
And I'm
uh,
telling you that this is a congenital lesion.
sir,
Yeah. Any
uh,
differential
sir,
that comes to your mind?
congenital DNA, sir, it's CCAM. Could
Yes. One differential, good differential. Next.
mm,
Now I'm just trying to make a differential out of you, right? So
okay.
CPAM or a congenital,
Pulmonary AV malformation. Okay. And
AV
oh,
malformation.
sorry,
Okay.
adenoid
Yeah.
malformation. Yeah,
Yeah.
yes, adenoid malformation.
Adenoid
And
malformations, and then
uh,
sequestration.
yes, interlobar sequestration.
Okay.
Uh,
Congenital lobar overinflation.
that's in the, sir, it appears
Upper
to be a
lobes.
adult chest. So
Yeah.
congenital lobar inflation. Okay. Captain differential.
Yeah, I'm putting it in a very low differential.
Okay, yep. Other.
So what is it? What do you think it is? Is it a sequestration? How would you
Uh,
differentiate it?
Sir, on uh, aortic phase images, I can see its supply from aorta and drainage onto systemic veins. So I can confirm it.
Okay, I don't have those, unfortunately.
Okay, and otherwise, sir, further imaging.
So, just to summarize, this
Yeah.
is areas of lucency or cyst-like areas in the right middle lobe, lateral segment, which
Yes.
is surrounded by area of differential hypolucency. Okay, which
Yes.
could be some sort of air trapping. I do not have any aortogram or venous phase, so my differential would be limited to CPAM and sequestration. And unfortunately, I do not have any other images, but this was a case of CPAM.
Okay.
Okay.
Okay. Okay.
Please
Thanks a
read
lot.
about it, Dr. Shazad.
Okay.
I'm provided with the XHS frontal and lateral projection of an adult patient. There is some elevation of the cardiac apex. However, the cardiac size appears normal.
Okay. So what is the very significant abnormality in this chest radiograph? What do you think? It's an acute problem.
So there is an opaque line along the left paraspinal region. Is traveling from the apex up to the below the level of the aortic knuckle.
Okay. Can you follow that line elsewhere?
Yeah, it's
And what do
going
you think
down,
it
I think,
is?
along the left atrial appendage.
What do you think it is? We are pretty short on time over here.
Yeah, so there a bit of lucency medially, and the trachea is also seems to be pushed slightly towards the right side.
Okay. So what do you think is something is happening over here?
There is relatively more lucent area in the left lower.
So what is
there
it?
is a horizontal hydropneumothorax could represent.
Good.
A
So
horizontal line.
pneumothorax, right?
Right.
And you can see also see some fluid over here, so hydropneumothorax. So this is a very acute finding.
Yes.
So that's a CT scan.
Right.
And what do you think over here? Quickly. So that's a pneumothorax, I know.
Bilateral pneumothorax, multiple.
No, that's not bilateral.
Small,
there's no pneumothorax over here. What do you think about this? This.
Small cyst.
Yes.
Bilateral and small
Yes.
cyst. And,
so there are multiple small cysts of bizarre shape.
Right.
And if I tell you that this patient also had some renal lesions and skin lesions, does any differential come?
Tuberous sclerosis with cystic lung disease and left side pneumothorax.
So this is not like a LAM. This is not lymphangioleiomyomatosis. The cysts are usually round, very well defined.
Yeah, but along with as you're telling about the angiomyolipomas, they are associated with tuberous sclerosis.
No, I'm telling you about renal lesions. I never said angiomyolipomas. Okay. I told you renal lesions. This patient had a prior surgery for renal cell carcinoma, and he also has skin lesions. Anything that comes to your mind? So we know that there are multiple cystic lung diseases, right? Can you name them?
Differential for cystic lung disease?
Yeah, differential for cystic lung disease.
Yeah, there is LCH. Langerhans
Yeah, yeah,
lymphocytosis,
yeah.
LAM,
Next, LAM.
LIP,
Next, LIP.
and
Next.
mm, certain cystic lung disease associated with the syndromes like tuberosclerosis and
Tuberculosis is LAM.
neurofibromatosis,
Neurofibromatosis
cystic lung
can do,
disease,
but it's not a very
VHL,
significant finding. Anything
is
else?
VHL, cystic lung disease associated with VHL?
Okay, I've never heard about that. There's another one that's called light chain disease that have lung cystic disease. There's one thing that you're missing. It's a named syndrome, and that's it. That usually happens with RCCs, skin lesions, and lung cysts, which are more bizarre shaped. They're not round. It have pneumothorax as well. So it's called Bert-Hogg-Dubé syndrome. Okay.
Oh gosh, yes. Sorry.
Yeah,
But
Bert-Hogg-Dubé. That's the only thing that you left out of the differential. Please go ahead. Just tell me the diagnosis. What do you think about it? It's quite a characteristic finding over here. So it is one of the cystic lung disease. We have
Yes,
gone
it
through
is
the
one of the
differential.
cystic lung disease. Yes.
Okay. We've gone through the differential. What do you think is this one?
It's a multiple bizarre shaped cyst with normal lung parenchyma.
I think so. These are not bizarre shaped. These are well round shaped. Don't you think? Don't you agree? If I
Yes,
say
sir,
they are round,
in the lower
predominantly
lobes.
round, right? In the lower
Oh, yes,
lobes.
lower lobes.
And they also have this rounded
Yes,
opacity to it. This thing. Can you see my pointer?
Yes, sir.
Like, look at this this dot-like opacity. What do you think this is? Any idea? We went through all of the cystic lung disease, right?
Yes, sir.
So this is not LAM. This is not LCH.
Yes.
This is not
LCH.
Bert-Hogg-Dubé. Okay. This is not amyloid light chain disease. That is super rare. I've never seen it. Okay. And one thing is left.
Sir, lymphocytic interstitial pneumonia,
Yes.
can it be?
Yes, it is LIP. So LIP cyst would have this vessel along with it. Okay. So this is a vessel sign.
Okay.
So it will have, it is perivascular and peribronchial cysts, predominantly in the lower lobes, with some peripheral atelectasis and fibrotic changes, but they're not very advanced over here. So this patient was positive for LIP. Okay, so I would just quickly go through this cystic pattern. So the top two diagram, basically when you see cyst and nodules, both of them, so that's PLCH, it spares the lung basis over here. Okay, when you see homogeneous cyst throughout the lung parenchyma, this is LAM. Okay, and the patient is a female. When you see the cyst in subpleural location, so this is usually honeycombing, and this is basically subpleural cystic changes or honeycombing, which is in fibrosis, or most commonly seen in UIP. Okay, and if there are like a bizarre shaped cyst, it could be Bert-Hogg-Dubé, but it's not shown over here. And this one is predominantly lower lobe predominant, so that is LIP. And LIP would have pericystic vascles. Okay, that's a characteristic sign. So this sign is very characteristic of LIP. Okay.
Okay.
Okay, I'm provided with this X-ray chest frontal and lateral projections showing haze in bilateral lung fields, giving a ground glass pattern. There is increased both lung volumes.
So lung volumes are definitely increased. What do you think about these lines?
So lines are, so there's a pattern of interstitial edema.
No, these are not like curly B lines. Curly B lines, they're usually over here, which can say that there's some edema, but I don't think so there's any curly B lines. These lines are over here. So these are the lines. What are these called? These are some reticular lines, right?
Yes.
So there is lower lobe predominant reticulation. See over this thing, this line over here?
Yes.
So
Yes,
it's a
sir.
meshwork of reticulation, right? And the other thing was important that you said the lung volumes are increased, correct? The
Yes.
diaphragms are flattened.
Flattened.
There are some fibrotic changes with tenting of the hemidiaphragm on the lateral radiograph. So what do you think is the combination of all of this? Reticulations, lung volumes increase, predominantly lower lobes with fibrosis. Anything that comes to your mind?
Emphysema.
Yes, emphysema. Good, very good. So lower lobe emphysema causes
COPD.
COPD would be upper lobe predominant, right?
Okay.
So these are the
Alpha 1
axial.
antitrypsin deficiency.
Very good, very good. So look at the upper lobes, they are less emphysematous. Look at the lower lobes, they are more emphysematous. Okay.
Okay.
So characteristic difference between emphysema and cyst. Emphysema does not have walls. You can see vessels going across it. Okay. Cyst would have definable walls. Both of them on X-ray would look at the same. You would have reticulations with increased volumes. Okay. You can differentiate them on CT scan. And when you have lower lobe emphysema, think about alpha 1 antitrypsin deficiency. One more thing that you want to think about lower lobe emphysema. What do you think it is? It always happen in IV drug users. Can you name it?
Mm, no, sir.
We have a lot of IV drug users here. So it's called Ritalin lung. Okay. So Ritalin lung is basically the people who abuse methylamphetamine, like the mood stabilizer drugs. What they do is that they take medicines, they crush it, and they inject it. They inject themselves. Okay. So Ritalin is caused by the cellulose or the binding material that is present in the tablet that deposits in the lower lobes of the lungs and causes lower lung emphysema. That is a very common cause of lower lung emphysema. It's called Ritalin. Ritalin lung.
Written.
Okay.
Okay.
And it's a
Okay.
very common question asked. I was asked, and at that time I didn't know that.